With the 2024 Rhode Island State Legislative Session over, we are back for our annual legislative status update.
Listen to find out what happened with bills in Rhode Island to expand no-cost insurance coverage of HIV preventative medications, preserve patient choice to access essential medications, and even kratom legalization.
Hello, pharmacists and friends. Today is Tuesday, June 25th, 2024. Welcome to the Regimen, featuring breaking public health news. Listen in to find out how pharmacists and pharmacy students can improve population health, health equity, and patient care through advocacy and education. My name's Liz Arnold. I'm a 6th and final year Doctor of Pharmacy student at the University of Rhode Island, working alongside Dr. Bratberg in the Rhode Island Department of Health.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. As a reminder to our listeners, the opinions expressed in this podcast by the hosts and guests do not represent the opinions of the United States government, the Rhode Island Department of Health, nor the University of Rhode Island.
We are thrilled to welcome the most recent outgoing president of the Rhode Island Pharmacists Association, or RIPA, Chris Federico, back for another state legislative update. Today we'll discuss the Rhode Island legislation relating to pharmacy, medication access, and other public health issues. Chris is a board-certified ambulatory care pharmacist, a nationally certified diabetes educator. Chris, we are very happy to have you back.
Great. Thanks so much for having me again this year. So so I feel like this is repeat. Once a year, I join the podcast and we talk and talk about some of the legislative wins that we've had. So this year's no different. So I'm really excited to share what we've been working on and also what actually came through the legislative process to be successful. So, and I just want to clarify, I am still the president. So I am until July 1st. So at the time of this recording, I am still the president. So thank you again for having me.
All right. And it is your second time being president, but that's a whole other
That's correct.
story when we do the RAPA history. All right, Liz, take us away. Start us off.
All right. So the first bill we're going to talk about is Senate Bill number 2255A and the companion House Bill 7625A. So these identical bills eliminate the prior authorization or step therapy requirement for prescriptions for any HIV prevention drug. It also prohibits the requirement of any copay or having to meet a deductible to obtain the prescription covered by the contract, plan, or policy.
Yeah, so it's great that we have this bill. Interested to hear Chris's response here. He knows as well as anyone listening that are URI students, my students, RAPA members, and you and I, Chris, all wrote or verbally testified for these bills in both the House and the Senate public committee hearings. Tell us a little bit about your experience working with the committees and the sponsors and other advocates. You are so involved. I think it's important to start off with how involved you are.
Sure. So this actually started last summer. We actually attended the bill signing with the governor. And I remember that when we got through...
And the bill signing, the previous bill,
correct,
maybe you want to talk about that.
So the previous bill was essentially that that pharmacists could prescribe HIV prevention medications, so PEP and PrEP, order lab work, and then also that the copays would be covered for patients as well, as it's mandated by the ACA already. One of the things that came up last year, though, was actually at the last hour or so in the legislative session was that prior authorization or a rapid approval pre-authorization was put into the bill language. So this was something that, especially if someone is on PEP or needs PEP, they need to actually have PEP given to them within 72 hours to be considered effective. And obviously, the sooner, the better. So this is something the bill sponsors and other advocates working on the bill from last year said, we really need to remove that for next year. So there was a concerted effort over the summer and the fall to really put this work together, put some language into the bill and actually get everyone on board to say, hey, let's remove the prior authorization. Let's also look a little bit forward towards the future. And as we know, injectable therapies are really important for patients that need PrEP. And so we also want to make sure the language was protecting patients that, especially if a new formulation came out that said, longer than 2 months at the time, that they would be able to access that medication. It wouldn't have any cost sharing or any copay. So we know with cabotegravir or Apretude, it lasts 2 months, but they're also looking at a formulation that lasts longer for 4 months. We wanted to make sure that the bill language actually protected that, so we didn't have to go back to the drawing board every single time that some new formulation was available.
And I think it's important to note that advocacy by Rhode Island Pharmacists Association passed a medication injection bill allowing pharmacists to have the broadest access to not specifically named drugs to be administered. So we passed the bill in 2021 and regulations came out earlier in 2023. And we specifically said any anti-HIV medication. So importantly, this bill make sure that it's patient access to those medications, but pharmacists have the authority to inject as long as they're immunization certified any anti-HIV medication.
So we started there over the summer, and then we really didn't hear much until probably earlier in the session around January. But the Senate sponsor, Senator Murray, she really worked hard with one of the policy analysts, Carlos Piero. I just want to give him a shout out. Worked really hard on making sure the language was correct, and then they brought in Rep. Kislak to be the House sponsor this time around. So with the bill, what we basically had to do was we sat down. It went really through the Senate fairly quickly, but we had some challenges in the House, and that was really where we struggled, for several months of trying to make sure that this bill was actually successful. So it wasn't just myself, it wasn't just the legislators, but we also had Amy Nunn from Open Door Health and also Phil Chan, and then also Bennett Klein from GLAAD. So we had a really strong workforce together. We met with the insurance companies just to make sure that they were on board with kind of what the language looked like. Definitely had some pushback there. There was concerns, once again, about pharmacist prescriptive authority and also the coverage. So if you recall from last year, Jeff, that pharmacists were identified as a provider under this bill, not across the board, but as a provider. So that means that they could bill for services and get reimbursed for that or ordering lab work. So that was something that we wanted to make sure that stayed in the bill and wasn't removed. So some of the edits that came through to us after passing the Senate actually tried to remove that. And so that was something that, you learn in this process that you really need to pay attention to all the minor edits that come across and the suggestions that are made, especially when they're not in line of the actual bill text. So when they come through in a separate message or an email. So we caught that. We caught that pharmacists would actually still maintain authority, but they would not maintain payment. So we've been talking about payment for pharmacist services for quite a bit on this podcast, and we wanted to make sure that it still was preserved there. So pharmacists maintained in the bill, payment was maintained in the bill. We ensured that long-acting injectables were maintained, and we removed prior authorizations or pre-authorizations, whatever verbiage they wanted to use. So that really ensured for patients that needed PrEP or PEP, as long as it was on the CDC approved list or recommended list, that they would be able to access it. No copay and no deductible would apply either.
Which is really how we should have all public health medications. So they should be available when you need them, when you want them. And the whole idea of pharmacists prescribing is that pharmacists operate in many different settings, in ambulatory care, in community care, in hospitals, that they're just another provider that when the patient's ready and willing and recommended to get these meds, they'll do it. We've already, from a URI perspective, Liz can talk about how much PrEP education she had, but we're rapidly expanding that this coming fall to meet the requirements of both the previous bill. And I think what's important in these steps is that, as Chris said, anyone who's advocating for a bill, every time you open up that bill or there's a new way to change the law, there's potential for mayhem. And so it's important to stay active in that.
And I would say one more thing that, this version of the bill was successful this year because we all had great communication with each other. And so there was not a time where a suggestion was made that myself, Dr. Nunn, Dr. Chan, Bennett didn't get on the phone together, message, email, whatever it was, and made sure we were all comfortable with it. We wanted to make sure everyone had their role and everyone had different say in different parts of the bill, and want to make sure we're on the same page.
So moving on to the next set of bills, we have Senate Bill 2378A and companion House Bill 7566A, which requires the Department of Health to amend its rules and regulations that allow for DEA-registered pharmacies to transfer electronic prescriptions at a patient's request. What this means is that DEA-registered pharmacies would be able to transfer Schedule II or C2 controlled substances.
Yeah, this was a bill that RIPA really wasn't on our radar. I was wondering why they're needed because I had seen, going all the way back till 2021, proposed language and that was finalized in August 2023 from the federal DEA that controls how controlled substances are prescribed and distributed. Basically, they said, hey, most prescriptions are electronically prescribed. Again, fun fact, Rhode Island was the first state to have every single pharmacy and every single provider able to transmit electronic prescriptions, although there's still some paper out there, Liz tells me. But but what's interesting, we were reading this morning that at the federal level, they say that you can only do one-time electronic transfers if state law allows. Our state needed to align with these more permissive rules. Liz works in community pharmacy. I just want to hear, is this an improvement now that this has passed Rhode Island and federal laws?
Yeah, this will definitely make things a little bit better. So we run into this issue once in a while, especially with Adderall and Vyvanse, the back orders and shortages that we've been experiencing the last year or so. So when prescriptions are sent to us and we don't have the medication in stock, and it's also not available for order through our manufacturers, we aren't able to transfer those scripts to another pharmacy that may have it in stock. So then it becomes this whole big back and forth between us, the other pharmacies, the patient, and the doctor, just creating a whole level of frustration. So being able to transfer the script will save time and energy for all parties involved.
Chris, what do you think about this bill?
Yeah, same here. When we talked about this earlier in the year, we didn't really know what to make of it. So actually I was asked by the bill sponsor, Senator DeMario, so during the HHS committee hearing about some thoughts on it. And I think when you hear why these bills are introduced, she works in the mental health field. So, she sees the frustration from patients going to one pharmacy and then having to go to another. Really, we always talk about delay in accessing medication or accessing care. So this is no different. So I think this was important. I think it does put a little bit of stress on, the Department of Health, I would say, or to really make sure that these changes are actually implemented. So it's something that I think we probably at the end of the day, it's going to be good for patients. It might expedite the process a little bit sooner for others than they actually wish. But I've worked in community pharmacy, and I think it's really, you have a patient come in and it's, it comes in electronically and you're like, well, why can't I just send that over? I have to call the physician or the prescriber, whoever it happens to be. They have to take that prescription, they have to go somewhere else. What if it gets lost or modified? There's all these things that can happen. And we're in 2024 now. I think it should be pretty easy just to send something over. And I believe it says they can only send it one time. Right. So it's not like you could go back and forth and send it to one. And then you probably call the pharmacy, say, hey, do you have this in stock? I mean, like we were talking about. And it would make things a little bit easier for patient care. And especially, again, the shortages have been indefinite over the past, 4 or 5 years, it feels like. So
yeah, and I work in the addiction field, and so I'm even thinking about access to buprenorphine and other opioids. So all these things that are controlled substances that people suffer if they don't have access to them. They can go into withdrawal. It's really negative, and for kids who are on them, and just focus in schools and things like that for these stimulant drugs and these ADHD drugs. I think it's really important where people aren't driving 100 miles to find a pharmacy. Now you can call a pharmacy. We have lots of pharmacies in Rhode Island, and it's close. But Liz and I were talking this morning about it's patient request is how the bill says. That's identical to the DEA language. But very often, I would say to our listeners or pharmacists listening, you should call the pharmacy to make sure that it's in stock, or negotiate with the patient to make sure that they're not transferring to a pharmacy and then they don't have it, because then you're back to the same situation Liz described.
Yeah. And all the community pharmacists that I've talked to about this seem really excited for it.
And I think one other thing too is, if you think we talk about smoking cessation on this podcast multiple times, and we say you have to catch them in the moment. So for any other type of, condition that we're treating, okay, what if that person doesn't get their medication, regardless of what it is, a control? If they don't get it, then they're either going to be delayed or they're not going to get it at all. And that could go on to have subsequent consequences. So I always think of the family that would come in with multiple children. One of the children needs to be on the medication, and then they don't get it that day. They go to school, something happens at school. You're trying to make it easier for a family. We talked about that with vaccinations before, to try to get everything, as simplified as possible.
Okay, I think we have some more legislation making it easier for patients to access their meds too.
Another set of bills passed by the General Assembly are Senate Bill 2086, which was floor amended, and House Bill 7365A, which prohibits healthcare entities from interfering with a patient's right to choose to obtain a clinician-administered drug from the provider or from a pharmacy of choice. So these bills were actually signed by the governor last night.
So, Chris, can you help our audience understand the importance and impact of this law? It's often called a white bagging bill.
Sure. So this is a bill that was actually worked on. I'll give some credit here because it wasn't a priority or something that our IPA actually signed on to from the beginning. So it's Mike Poirier, who's one of our counselors, but also works at Lifespan. This was actually one of his master's projects from a few years ago, and he actually helped to get a sponsor. He got Rep. Caldwell, I think it was 2 years ago, he got Rep. Caldwell to actually introduce this bill really late into the session. But he did a great job at actually coordinating all the advocates. So he worked really closely with Harry, so that's the Hospital Association of Rhode Island. They really spearheaded all the efforts. Lisa Tommaso is their executive director. She did a wonderful job, and she's well experienced, so no surprise that this actually was passed. But he worked with RASHP, which is the Health System Pharmacy Association in Rhode Island. We actually worked with some of our national associations, so APHA wrote in, I believe ASHP wrote in as well. And really what this bill is something that not only Senator Udafusa, but also Rep. Caldwell really wanted to work on, but many of the health systems really were impacted by white bagging. So I'll just kind of break it down really on a general level. But basically, when this typically happens in the oncology field or specialty medicine field. So if a patient needs to get a medication that's administered in the clinic, chemotherapy, wherever, the patient will go to the hospital or one of their associated clinics. And then even if the pharmacy has that product on site, the insurance company has to send over that product over to their clinic, and then they would administer the drug. So there's many reasons why they do this, but in how it stands before this bill was passed, that they could actually mandate where that patient actually received their medication. So the patient could not choose. So when we talked about what some of the core tenets of this bill was, that the patient needed to have the right to choose, right? So an example where this is kind of a problematic, would really be if a patient needed to get a different dose or a different drug or something based on lab work or something that changed drug interaction. Right now, they would have to wait till that drug comes in. They would have to request a new dose, a new drug, or whatever it is, because otherwise they couldn't administer that drug without actually, losing the money or the value of that product. So in many circumstances, they actually wouldn't be able to, they heard that they wouldn't receive reimbursement for that drug. The patient wouldn't get the medication. The patient goes, a day, 2 days, a month without getting their medication. So it's a patient safety concern. And we've heard delays on therapy. We've heard all these other things. So it's really something that they worked hard on.
And it was powerful testimony when I hung out at the State House for 5 hours on a weeknight because Chris was unavailable. To be clear, he has spent many more hours there than me. But it was a packed house, and I will never. I've heard a lot of testimony, given a lot of testimony, but this mom who sat right next to when you testify, you may be sitting next to the person who is against the bill. So it was our friend from the pharmaceutical benefit manufacturer or the PBM manager person. And the committee was grilling him and saying, like, why is this? He's like, well, we just represent the insurers and we're trying to have affordable care, this usual PBM kind of standard language. And then they're like, oh, man, why don't you talk about what this is? And she said, my child needs a drug, suffers without it, missed the drugs, like the drug wasn't available because of these delivery problems and had to be hospitalized. And so she's sitting right next to this guy, right, professional lobbyist for PBM industry. And it was just such a juxtaposition where this person's like, here's my story. This is horrible. An unnecessary hospitalization that literally costs the insurer even more money because they're trying to cut costs by not letting me choose where it is and not letting the hospital actually administer the drug either because they can. They will lose money if they stock all these meds all the time. So I think it's a really important thing, and there's a movement towards, again, patient choice and making sure everyone can access their medications.
And people would ask during the testimony, why can't you just give out the drug again? It's already labeled. It's already specific to that particular patient. So you can't just label that drug, prepare it, and do all those things. In some instances, it might need to be compounded, right? And you can't just give that out to another patient. So then essentially that drug has to be discarded, and the institution, because they can't get reimbursed for it, they would actually lose on it. So some larger health systems probably can eat the cost of that, but some of the smaller institutions or smaller hospitals, they probably can't do that because these meds can be tens of thousands of dollars. So it's really critical that patients can have the choice, and it really removes a barrier from patient care at the end of the day.
Okay. Now I know you've been waiting for this, Chris. Frederico, or is it Federico?
Federico.
It's Federico? Okay. Sometimes Chris is called Fred, and then what was your other new name that you were called? Mike?
Yes, Mike. People just, I don't know.
He's called a lot of things. He's pretty much incognito here as his actual name. But as of today, June 25th, we have a General Assembly passed policy legalizing in Rhode Island access to kratom or kratom. We'll call it kratom. It's not yet signed by the governor, so we'll hear more about that. So that's Senate Bill number 2704A and House Bill 7231A, which authorizes and regulates the distribution of a product known as kratom. Not the active ingredient, but just this product, this ingredient. I believe we talked about it, right? Dietary ingredient, Liz. And I'm looking at Liz because there is an episode dropping today, a stat regimen on kratom. And so you should tune in if you missed that episode.
Yeah, Chris, Jeff and I talked a lot about your efforts to connect policymakers with the data or lack thereof of kratom's safety and efficacy. What do you think is going to happen next?
Not sure. I think, I'm really not sure. But I think, Jeff probably can recall this pretty vividly. When this first came out, I think a lot of people have strong feelings pro or con for this. I think, but it's really hard in this type of process that, if we have concerns about a bill and we have concerns about, okay, your concern about kratom is that it doesn't have safety or efficacy, it doesn't have long-term, doesn't have a robust safety profile, whatever it is. Well, how do things get approved in the United States, right? We have FDA, we have FTC, we have Cannabis Commission here in Rhode Island. So, I said, well, I might not agree with why someone's using the medication or a supplement or whatever it is, but if someone goes through the correct process, I think that's important. And if they do it, who am I to say, right? I might not use it. Other people may benefit from it. There's, some people take airborne and stuff when they go traveling and in different,
homeopathy.
Yeah. So
I'm going to withhold my comments for right now.
Right.
But anyway,
is
there a homeopathy gals podcast? Because there's a kratom gals podcast that apparently I was on.
Yes, your testimony, and you're actually someone that they actually applauded. They did so, but I think. We can go even down to vitamins, right? Vitamins are not effective for the most part in many people that are, nutritionally sound and eating and all that type of stuff. So there's very few instances where people actually would benefit from multivitamins. But why am I going to go out on a limb and say, well, you can't take the multivitamin? There's no data.
But they're also proven safe because they're regulated by the FTC.
Correct. Exactly. Back to that original point. So, when we Jeff is an addiction, medicine specialist and has, quite a bit of knowledge in this area. So I kind of deferred to him on this. But I said, what I think we should do is really just say, well, here are the different paths that we think should be undertaken. So if there's a trial that's going on, which there's trials that are going on, I think we should wait for them. If we can wait another year or so many more months, if they just want to look at safety, that's important too. Or if they want to do something like we do here in Rhode Island or in many other states with the cannabis control commissions. And I just think we need to give solutions, and I think that's really important. We can't be critical and just say we just oppose things for the sake of opposing it. We would be the first people to say people are biased and people have these opinions because of whatever affiliation. I think we need to give solutions and say, hey, if you do one of these, then we're comfortable, and that's how we ended up doing it. So, I think the testimony went through the House last year. We're expecting it to go through again this year. The Senate, there was a lot of pushback. I was pretty surprised, to be honest, that it actually went through, even got elevated for a vote. But I think every year there's different things that happen, and I think there's reasons why things get elevated or not. But I think our main point was we want to make sure it's safe. And so some of the suggestions that, Dr. Brapper looked into was, well, what about using naloxone? So are there cases, it acts on the opioid receptor. So what does that mean? Is there a potential for overdose? And you keep hearing on podcasts, Reddit, and all these things, no. But then if you actually dig deeper, people say, yes, I got, I had withdrawals from stopping it. Yes, there's this person that actually, there's no overdose, but then you do literature reviews and you actually see that patients actually had overdosed from taking too much kratom, intentionally, unintentionally. It really doesn't matter. So how do we reverse kratom? So naloxone, fortunately, which is available in a number of different areas in community pharmacies now, and out in the community, actually showed to reverse kratom overdose. Now, in a lot of those instances, kratom overdose didn't cause death, but naloxone actually prevented them from a more severe consequence. So again, like we've been saying about vaccines and other things, trying to reduce the harm and trying to minimize it. So you could still have some sort of, negative consequence, but if we can reduce it from, accelerating to death, respiratory depression, whatever happens, that's obviously a good thing. So that's where we made some suggestions. We would ask for naloxone to be, available at whatever those places, because many of them would not be pharmacies. They would actually be at regular, as we heard, mom and pop shops. They said no gas stations, but last year was gas stations, wherever it would be. So Jeff, I think you're itching to talk about this part.
I agree on everything. It is all about safety and efficacy about things. I agree that, as pharmacists, we'll talk a little bit about scope of practice, and our scope of practice is to choose medications and devices that are best for that patient and patient-centered care. And that's what Liz, you've heard that all throughout your education. It's all about what does the patient want. But if you have a substance, and mind you, the amendments to the bill did add levels of regulation. We feel not to the extent that we had testified before. There's, again, I know everyone doesn't want to wait for clinical data, but I want my patients to have the best drug, and I think there are better, more safe, more effective medications. Some people, this gentleman who testified said that drug, buprenorphine, didn't work for him, but kratom, even with the regulatory scheme, just is not going to, that's proposed and is yet to be signed by the governor. I don't think that there's enough data to have it be safe and effective.
And I think the one thing that we talked about towards the end was, yes, patients that use kratom right now, they probably understand how to use it. They know the
Patient's always the best person, right?
Right. They know the side effects. They've been dealing with it. They know where to get what works best for them. But what I was concerned about, and I think both of us were really, was what about that patient that's never tried it before? Maybe they're opioid naive. They heard, hey, this helps. I have back pain. I want to use it. They say, this didn't work for me. Let me double it. Let me have more, whatever happens. I mean, people do it. I run, as we've talked about on here, and I have friends that would go and take like 2,400 milligrams of ibuprofen before they run because they didn't want to have pain and inflammation. And then I said, well, there's actually a lot of case reports, and actually it's one of the highest rates or highest reason for people to get acute kidney injury while running long distance is actually taking anti-inflammatories. So we talked about that of why would you decide to take 4 times the approved dose over the counter, right? So people will do that, and I think it's just kind of protecting those patients that are naive, and I mean naive in terms of the medication or the substance, right? Exactly.
Yeah. Have no tolerance, yeah.
Right? Or that they, again, on the label, people need to be informed of what it's for, and they talk about, hey, it's good for anxiety, good for pain.
Yeah, but there's no requirements on this. Like in the Kratom podcast, we talk about how supplements like even melatonin or other things, say this is for heart health or GI health. Like, I don't know what kratom is for psychiatric health. I mean, it's one of the few over the counter. Again, you talk about ibuprofen. You don't develop tolerance to ibuprofen. Like, that person's not taking 2,400 because 600 doesn't work. They're just taking a bunch because maybe the internet told them, right? If Liz takes too much tart cherry juice that we talked about on the Navindra Serum podcast,
I would sleep for a week. I would sleep for a week.
But you don't develop tolerance to it where you need a gallon, next month because you've had tart cherry juice too often. So
tart cherry, it was.
It
was. Yes, you did. This is not planned, but I actually used tart cherry supplements during my early stages of running, and actually it was. I anecdotally. I can't
and now
say,
you're on dialysis.
That's right. No, but it did show that.
The more you know.
I used to talk to the place that was selling, and I said, there's more literature on reduction of Tylenol use. So I think you should be really marketing it towards reduction in Tylenol use more than like this is a cure-all. This is good for arthritis and whatever, all that stuff. But I think back to this whole safety thing. I think that's really, as pharmacists, what we're looking out for and making sure. Again, if there's different doses for different indications, we thought that should be on the label. There's many drugs that have different, mirtazapine, for example, different dose for sleep versus different dose for, depression. So I think, we need to keep that into consideration.
RIPA and other pharmacy advocates supported several other bills that didn't make it to the governor's desk this year. A few examples include pharmacists prescribed and reimbursed smoking cessation services, progress on payment reform, inhaler copay thresholds, limited the cost of diabetes supplies, and increased glucagon access. So what happens next with these bills, and what are your priorities for next year as an organization?
So every year we get together, kind of prioritize and talk about things that we think might pass or work with the bill sponsors again. Unfortunately, they actually go back to ground zero once again. So you have to reintroduce them. So you have to make sure that the bill sponsor still wants to do it. If they don't, then you have to find
that they're elected.
Well, yes, that's correct.
It's
an election year. So really nothing's probably going to happen until, after November or, after the election at least. So, some of these bills we've already started to talk about what we would do differently next year. For the smoking cessation, we were very surprised it didn't get through the House last year. It got completely through the House, but every year priorities change. And so that's something we have to really look at once again. For payment reform, for payment for pharmacy services, that's something that we were, actually encouraged to sit down over the summer and have a more in-depth collaborative effort really to focus on passing that for next year or learning more. I think we put a lot of time, effort, and resources. But once we got the right people to actually consider looking at it, I think it just was too much information for them to really consider in the later stages. For the inhaler copays, I think one thing that's been done is that inhaler copays have actually been dropped for most larger pharmaceutical companies. So I think it was trying to lower even further from that. But there were some other things in there, like ensuring that spacers or holding chambers were actually included. So it did a little bit more than just lowering that. Diabetes supplies, that's another one that gets through the Senate every year. I think there's challenges with them because there's so many different devices, there's so many different options, and so insurers, I think, are a little hesitant of just giving carte blanche across the board and saying, hey, you can do whatever you want with these things. So I think it's a little challenging. Glucagon access, this was introduced this past year. Actually, it was introduced by me. It wasn't an RIPA effort. So I actually had worked.
And I testified on behalf of Chris.
Yes, and thank you, Jeff. So that was something that, I've seen as a clinical pharmacist and also as, someone that has a family member that has type 1 diabetes, that, glucagon is incredibly expensive. Even, in one experience this year, right actually at the end of session, went from being covered to needing a prior authorization. You submit a prior authorization, it actually isn't approved. It's like, well, what do you take if you're having a low blood glucose, event?
There's no tier 2 or tier 1
for type 1. So, there's not like, okay, juice didn't work. Well, what do you go on from there? You end up having to go to the hospital or someone calls 911. So I think that's just one of the challenges, that we need to educate a little bit more of, hey, there's not many patients in the state that actually need that. But the impact if someone goes on to develop a hypoglycemic event can be extremely costly to the healthcare system with, an ED visit or even admission. So, we have to go back to the drawing board, see what we thought needs to be changed. If something needs to be amended, we can try to work on that earlier. I think, unfortunately, every year this stuff gets changed and we get together with the opponents really the later stages of session, and it's really unfortunate it comes to that. So, I had some good conversations of how can we be more proactive. You ask about students writing testimony, understanding why this is important for their profession. Like we got our licensure bill passed last year to lower licensure fees. Students only have to renew once for their 5 years.
This is going to stay in Rhode Island, and
so it's retention.
She's going to get. It's about retention. It's all about Liz.
So I think you have to find your passion as a student, and if you're someone that's involved in like tobacco cessation or if it's diabetes care, I think at the end of the day, you say, how can I get involved? To your professors, to your coworkers. And, this is just one mechanism.
And if you sit next to Chris, you're going to be told you're going to testify for all the bills. So that's usually what I do.
And I think, I think the students that you've had and other students that have come up to the State House, I think they've done a great job.
And a lot of former students who've written testimony and submitted and done all those things.
You can write, and I think it's just continuing to talk to your legislators of what's important for you and making sure that they know that that's something on your priority list for the year.
Liz, take us out.
Wonderful. Chris, thank you so much for joining us today and helping us stay up to date on our state legislation.
Be sure to follow us at PharmD Pub Health. That's Pharmacist and Pharmacist, PHARMD as in Dr. Pub Health on Instagram. Connect with us on LinkedIn. Turn on post notifications so you never miss an episode, and smash that subscribe button. I was told that we've increased our subscribers, so you're doing it on Spotify, Apple Podcasts, YouTube, or wherever you listen to podcasts.